Okay, so we will be giving you first an overview. Then Nikki, Laurie, and Sarah will present about the Northwestern Toronto Vpsos. Then David will present about a public health update, specifically a report, and then I will wrap up with a question and answers and final remarks. So just to remind you of what's happening in Ontario in case that some of the attendees that we have today, and we have over 300 attendees, I understand, in case that you have not been very involved to this point. So Ontario is undergoing a health system transformation, beginning with the formation of the Ontario Health Agency. The Ontario Health Agency is bringing together several what's called legacy agencies, Cancer Care Ontario, HQO, eHealth, Gift of Life, HSSO, Health Force Ontario, and then it's also creating a new entity for mental health and addictions, a mental health and addiction center of excellence. That's at the highest level. From there, there will be 5 regional offices, which is my understanding. Those will happen very soon. It is unclear to me at this point if those will be temporary regional agencies at this point or permanent regional offices. But we shall hear, I believe, in the next few weeks about those regional offices, which will then bring from the Ontario Health Agency the next layer of support for health system transformation. We will have, as you know, the Ontario Health Teams, and those will be reporting to those regional offices that I just mentioned. And then there will be an amalgamation of public health entities, and that number 10 should be, and again, this is not government speaking, this is RNO, Doris Grinspun, projecting analysis. That number likely will not be 10, nor will it remain the 35. Probably it will be something like 11, 12, 13, likely not 14, because that was in a report of the previous government, so cannot be 14. So probably, who knows, 11, 12, 13, you do need to know RNO has been in support of that amalgamation, not exactly which number, but overall in support to try to coordinate better public health work around the province. This is all to respond to the Quadruple Aim. We spoke a bit about this last time, the Quadruple Aim of improving, first of all, patient experience, improving patients' outcomes and population health outcomes, lowering the cost of care, and improving provider experience, which is the last Quadruple Aim. The first 3, improving patient outcomes or population outcomes in general, is more talked about. Improving patient experience and lowering cost of care, that used to be known as the Triple Aim. What was added with the years is the Quadruple Aim of provider experience, because it is pretty clear to many people that if staff don't find meaning in their work, if staff are not engaged on their work, nothing of the rest really can happen. And that's why the improved provider experience was added, not here in Ontario or in Canada only, but around the world. And we can certainly share some good articles about that. You can also Google both the Triple Aim and the Quadruple Aim, and you will find a lot of important information there. Let me comment a bit about lowering cost of care. Lowering cost of care for RNO means that if you have less falls or less injury after a fall, of less pressure injuries, or better breastfeeding in primary care and in public health, or less women violence, or whatever it is really, one of the 54 guidelines of RNO, you will lower the cost because you are lowering complications. So for us, We don't shy away from that. We are supportive of that, and we work with organizations to try to improve their outcomes. And you will hear from this OHT how the quadruple aim is being materialized through the work of PBSOs within this OHT. So where are we with the assessment process? First of all, 31 organizations were chosen to move to full application, and those applications are due October 9. And then there is a second round of 41 applications, and we are engaged with several of the OHT partners to support them in their work forward. These are the OHTs that were invited to the full application, and you can see in orange or red the Northwestern Toronto OHT, which was the first to sign with us an agreement to work with RNO through the Vpso program and process as part of their OHT work. And you will hear directly from them what is it that we are doing, and we will augment that. There is a second application that will be signed, I believe, this Tuesday, and then there is a third in process, and the future continues to move forward. We will take a limited number on the first round because we want to make sure that they all work very well and that they all are getting the actual supports that we are committed to provide. And you will see from my colleagues when they present that our work is very intense, very involved, and very hands-on in supporting them to do outstanding work. These are the OHTs in development, the 41 that I mentioned there. We are also working with the couple there, and we will be talking more about them in the future. More and more, you will hear from OHTs presenting at these events. Every time we hope to bring another OHT that is working with RNO so that you can get a really first-hand sharing of their experience, because we believe that their experience will help many other OHTs, including the materials that we're sharing with them, the materials that we will develop today with them together, etc. So what does it mean BPSOs in OHTs? Well, BPSOs in general, we have over 900 of them around the world, 550 in Ontario alone, are, so to speak, labs that take our guidelines in a very systematic way, learning from us through implementation science and social movement action on how to advance evidence uptake and sustainability across all service organizations and academic institutions to enable practice excellence and positive client outcomes through this work. As you will see in future slides, this will say that this is transforming care through evidence-based practice, which is what we discussed this morning with our OHT that has been all day here with us. We have at RNO experience since, first of all, the guidelines, where the first guidelines came out on 2001. The program is supported by the Ministry of Health and Long-Term Care since 1999. And in 2003, we launched the Best Practice Spotlight Organizations. And in the OHT that is presenting today, 4 of the 13 organizations are BPSOs, 2 in progress, and 2 in fact are founding members of the OHT that is here meeting today. So we have what's called BPSO Directs. Those are organizations that work directly with RNO. We have BPSOs National Host. Those are usually governments, like in Ontario, our government, but actually in Spain, the federal government, in Chile, the federal government, etc., that have taken the program and run this program with our support and materials in their own countries. Of course, we don't spend a penny on anything outside of Ontario. but they actually use the materials and put the resources locally to advance the work in their jurisdictions. And now we have the Vpso regional hosts, which are within the countries. Some ministers that want to run faster, so that's the example in Spain. 7 ministers in Spain are running the program in addition to the federal government, are running it faster in their own provinces. And of course, now we have the Vpso OHT, of which we will be sharing with you the first one that is on board. And next time we will be sharing the second in October. And then we have Vpsos that are also for academic organizations. Best practice spotlight organizations for Ontario Health Teams. The goal is simply to optimize patient outcomes through the use of evidence, that's number one, and robust staff engagement. The level of staff engagement that Vpso have, whether here in Ontario or abroad, is second to none. You can just picture, and some of my colleagues will speak about that, that when we will do the training for our OHT, December 2nd and 3rd of Champions, we're bringing people from all those 13 organizations to be trained together on evidence-based practice, to be trained together on how to engage other staff into this, and to actually work with the organizations to deliver together. And you can just picture the excitement that that will create. And we are videotaping all these activities so we can share with others. These are organizations that their commitment to evidence-based practice and to enhance health outcomes for all patients and across all sectors within the teams is absolutely firm. They sign an agreement with us and they need to report. Not only they get support from RNO, they also need to report on the progress. They actively foster a sense of leadership amongst frontline staff. So when you speak about the quadruple aim of meaningfulness of work for staff, you can start to understand that when you give people the tools, the know-how, and the power to be able to create practice change, that powers, not empowers, but powers frontline staff to not only do good, but do the best that they can every single day. And it serves, as I said, all of the quadruple aims, but actually also the quadruple aim of staff engagement. I will now pass it on to Nikki Mann from Villa Colombo. First to you, okay, to Sarah Kirkup, Luma Care. And let me tell you, Sarah, Luma Care is not a Vpso at this point, nor was involved in the Vpso movement. And this is very important because we do want you to understand that in an OHT, not everybody needs to be a Vpso, and it could be an OHT that has no Vpsos in their midst. You still can join this journey because we will train you from beginning to end and support you all the way. I must say also that the program with the OHT Vpsos is a 4-year program. The agreement of the OHTs with government is a 5-year agreement where then they can be reassigned as an OHT. We are doing it quite purposefully 4 years because we already have mapped out what will happen in year 1, year 2, year 3, and year 4. And in year 4, we will produce a report that will go to the main OHT, to the Northwestern Toronto Vpso OHT, and in the others to their umbrella OHT. You will also hear then from Laurie Martin from Humber River Family Health Team, also not a Vpso, but you may have seen Laurie in the video that we tweeted about a month ago, and she was sharing her excitement on being part of the Northwestern Toronto Vpso OHT. And then you will hear from Nikki Mann, Villa Colombo, who already is in the process of being a Vpso, so we'll bring you the perspective of what it means when you are in the process of being a Vpso to join this larger initiative. With that, I leave you with Sarah for a little bit. Let me stop for a minute in case that there are a few questions. We will take 2-3 questions if there are. If not, we will move to Sarah and take questions later.
Northwestern Ontario will be involved. Northwestern Ontario, if they'll be involved.
Was not Northwestern Ontario, it's the LIN. I'm assuming you are talking about the LIN. Well, I cannot speak about the LINs. We will hear more about the LINs from the government. As you know, the LINs are merging into the larger agency and then form the 5 regional offices of Ontario Health. I would be delighted if Northwestern Ontario is one of them, simply because Northwestern Ontario, quite frankly, was the first LIN that actually signed to be a VPSO. So Northwestern Ontario, LIN has a lot of experience being a VPSO, a host, in fact, for their region. And also they work very closely, and we are working very closely as a consequence of that with indigenous communities, I believe First Nations communities, with many of the chiefs, and that connection was done by Rhonda Crocker Elliott, who is the CEO of the Northwestern Ontario LIN. Thank you for asking. I will be delighted, of course, because we know their work, but I am not sure where that process is at this point. Thank you for the question. We can move on to the next, or yeah? Okay.
All right. Hello, everybody. My name is Sarah Kirkup, as Doris said, and I am from LumaCare. My presentation will basically describe the Northwestern OHT and how it relates to the BPSO. Just want to, first of all, share who our partners are. We have partners that span across 11 sectors. So the primary care, the partner is Humber River Family Health Team, and Black Creek Community Health Care, and Unison Community Health Services. Secondary care is, our partner is the Humber River Hospital, who is our lead for the Northwestern OHT. Rehabilitation and complex care is represented by Runnymede and West Park. Home and community services are represented by LumaCare and St. Eliz. Mental health and addictions is CMHA, Coda Health, Loft, and Addiction Services of York Region. And we also have residential and short-term care sector represented by Villa Colombo. Our members already have many informal partnerships that exist between members, including collaborating on strategic initiatives, utilization of services, and planning for community and social services. As Doris mentioned, 4 of our partners already are involved with the BPSO, with Villa Colombo and Humber River as pre-designates, and St. Eliz and West Park are designated. And they have implemented BPGs in healthcare, rehab, and long-term care settings. Each of our partners offers complementary services across the care continuum. Some examples of our existing partnerships include Rapid Access Addiction Medicine Clinic, where you have Humber River and Addiction Services of York Region partnering. We also have a psychogeriatric outreach program between West Park and Villa Colombo. There's a prenatal collaborative between Humber River Family Health Team, Black Creek, Humber River Hospital, and Unison. And that's just mentioning 3 of very many others. Okay, so as Doris also mentioned, that we are the first OHT to sign an agreement with the BPSO OHT as a BPSO OHT, and we're quite proud of that. Our catchment area, we service the north and west regions of Toronto. Our target population was strategically selected in relation to disease prevalence within our region and in alignment with key integration measures identified in the OHT guidance document. Some of those measures include avoidable emergency visits, decrease in ALS days, decrease in unplanned readmissions within 30 days of discharge, patient and family and caregiver experience. Our focus will be on chronic disease management, and we will be using the population health management approach. So some of our data. Oh, not that one. Okay. Just to give you a sense of some of our distinctive demographic features, we have higher percentage than the average in Ontario in many of our areas of demographics. So for instance, percentage of low income persons is 27.6 in our area, whereas the Ontario average is 14.4. The percentage of immigrants is 54.9%, whereas the Ontario average is 29.1. The percentage of visible minorities is 60.8%, whereas the Ontario average is 29.3. And when we look at seniors, a percentage of seniors over 65 and over is about the same at 17.1%, whereas the Ontario average is 17.6. But if you look at the percentage of seniors over 75 years of age, we have 8.6%, where the Ontario average is 7.9. Other factors that we looked at are education and low income. Again, we score higher than the Ontario average in those areas. We looked at the percentage of Francophone and Indigenous population. We come in lower for the Ontario average. For Francophone, it's 1.4%, and Ontario is 4.7%, and the Indigenous population is 0.6% in our area, where the Ontario average is 2.8%. If we look at the disease prevalence in the northwestern Toronto OHT, we do have predominantly high number of chronic disease clients, with diabetes at 17%, persons with asthma 16%, high blood pressure is 25%, COPD is close to 10%, and mental health and addictions is at 9.4%. And through that, we've identified population areas that we will be focused on in the next 3 years. With the year one, we're nailing down specific populations that will be focused on that involve chronic disease management. So all of the actions that we are developing will have those socioeconomic demographics in mind. So we will be including principles of health equity, health literacy, access to care, health promotion, and prevention. Okay, with that, I'll pass it on to Laurie.
All right, so hi everyone, my name is Laurie Martin. I'm from the Humber River Family Health Team. And I'm just going to go through a timeline of the establishment and co-creation of the Northwestern Toronto Ontario Health Team BPSO. So our journey began in May of this year, where the RNAO provided a letter of support regarding the role of BPSO in our OHT self-assessment submission. And then in July, we had our first meeting together at the RNAO. Representatives from each of the partners in our OHT were in attendance, and we were introduced to the OHT BPSO model. At this meeting, we came to a consensus to move ahead with the BPSO partnership. And following this meeting, there was a contract signed by the RNAO and all participating partners in our OHT. For the organizations who already are BPSO, their contract remained in place. And then in August, we had our second meeting together. This was a planning meeting. And during this time, we developed our draft work plan and discussed collaborative approaches for creating our OHT BPSO. We also had opportunities for dissemination around this time through social media, a press release, and as Doris mentioned, videos of the experiences of some of our members of the OHT. And then today is our third meeting together, and we're working on establishing an approach for capacity development of our respective interprofessional team members across our OHT. And we're specifically working on planning our first champion training. And also through this webinar is an opportunity for dissemination. And we'll have representatives from our OHT also participating in a panel at the RNAO's Nurse Executive Leadership Academy on Thursday. So our full OHT application will be submitted on October the 9th. And in December, we will be having our first best practice champions training. And we're doing this collectively as a team to support evidence-based practices and guideline implementation across our OHT. So I'll just briefly provide an overview of our 4-year contract for BPSO designation. So for year 1, we're working on creating an infrastructure, training champions, building relationships, and planning for the implementation of our first best practice guideline. Years 2 and 3 will focus on implementation and evaluation of the remaining guidelines. And year 4 will focus on sustainability planning. So these, I'll go through the 4 best practice guidelines that we have collectively decided to implement. So care transitions and person and family centered care are mandatory for all best practice or BPSO OHTs in order to address the goals of system transformation related to integrated care and patient experience. And these guidelines will be implemented across all sites within our OHT. The remaining 2 guidelines are pressure injuries and fall prevention. And these clinical guidelines were agreed upon to address the priority needs of the patient population of the Northwestern Toronto BPSO OHT. And this was an assessment of what was already being implemented by 4 of the existing BPSOs within our OHT, and what would be priorities for the services being offered in the majority of partners within our OHT. However, for some of the organizations within our OHT, the pressure injury best practice guideline is not applicable. And so that guideline will be replaced with engaging clients who use substances. And I'll pass it on to Nikki.
Thank you, Laurie. Hi, this is Nikki. I'll be working through and talking next about what the next process is and what we've been doing. So as both Sarah and Laurie talked about, everything they've talked about, it's about developing an infrastructure, which is actually our steering committee work that we've done to date. So this is our steering committee. In order to get any program in place, you need to develop an infrastructure. And we started off with identifying what it is that we wanted to do, coming together, collaborating, and wanting to implement best practice guidelines through this steering committee. Each organization from here on forward has assigned a lead, BPSO lead for their organization. And we'll be looking at establishing local BPSO structure, including a lead for each BPG as Laurie had said there are 4 best practice guidelines that will be implemented, and it will be up to the organization to identify lead individuals who will be taking on each best practice guideline and implementing it through the organization. Year 1, we will be looking at patient and family-centered care. And then into care transitions, falls prevention, skin and wound. Each BPG will have a working group to implement the guidelines selected, and each teams will be working, selecting cross-sectorial staff in aligning with recommendations identified. So as an organization where we're in year 2 of BPSO implementation, this is going to be a little tricky and challenging, but all nonetheless very exciting, because we're going to have to put together a collaborative approach in identifying those teams and how we all communicate all the information and work together with that, with working groups. Implementation, what does that look like? Well, we've confirmed what our first BPG is, which was patient family centered care. And next steps from here on are about identifying what the gaps are, doing an analysis collectively and within our organizations, and identify what the gaps are and look at recommendations which would best suit our organization or Ontario Health Team in moving the best practice guideline forward and implementing it. So establishment of a BPSO infrastructure and a reporting and accountability structure to guide the work of the BPSO lead and the implementation teams at the participating sites. Implementation of a minimum of 3 RNAO clinical best practice guidelines at each participating organization at the Ontario Health Team BPSO during the term of the agreement, one of which is care transitions, and any next editions of this guideline. The other 2 clinical guidelines as discussed are family and person and family-centered care, assessment and management of pressure ulcers for the interprofessional team, preventing falls and reducing injury from falls. It is highly recommended that the Ontario Health Team BPSO consider implementing the person and family-centered care BPG across all sites, as it aligns with the expectation of Ontario Health Teams that the patient and family experience will be the center of the teams and of the healthcare delivery system as what's coming up and what will be developed in the future through the Ontario Health Teams. So working together, implementing a framework that has the patient resident in the middle and all other services surrounding it is what we will be focusing on year 1 actually. So what does this look like? There'll be a lot of support systems in place to us, given to us by the RNAO BPSO coaches, the BPSO network, to support the local implementation. We will be involved and participating in monthly virtual BPSO knowledge exchange meetings to share key learnings. We need to learn from each other, support each other, and move the best practice guidelines forward. Integrate applicable RNAO BPG order sets into electronic health records for those guidelines being implemented. Documentation is great, but we all need to be on the same page with health records to make sure that we're all saying and identifying the same gaps and speaking the same language when it comes to documentation and implementation. Mentorship by those Ontario Health Team BPSO organizations that are currently BPSO pre-designates to share experiences and strategies related to the planning. So together we're going to identify, plan, and implement selected evidence best practices throughout the organizations. And to do this, we need to build capacity. And what does building capacity mean? It means that we will be identifying and training champions. And champions starts not from the top, although there are leaders that are champions. It starts right from grassroots, which is at bedside patient resident care. So we will be identifying and educating champions at the forefront who will be involved, who will be getting the education, a 2-day education in December, to take these best practice guidelines and moving them forward, because all the care is provided at the bedside. And then we can evaluate the success through quality indicators. So capacity building, how we're going to do that? We're going to have training. We've identified what the training is going to look like already. We'll recruit champions within our organizations. There will be a 2-day education in December of this year through monthly exchange meetings and from a coach that will be provided to all facilities, RNAO coach, meeting weekly, bi-weekly, or even monthly as required, and mentorship and coaching from existing Vpsos. So technically what we will be doing is developing change agents for the organization, starting at the front line and moving best practices and implementing them forward. And that's key and critical in any organization, is taking and involving the frontline staff and engaging them to be the successful individuals implementing the guidelines. Well, with every project in place, there has to be a process to evaluate. And everything needs to be evaluated, reviewed, analyzed, and re-evaluated to see if we've been successful. And the way we're going to be doing that is by collecting baseline data prior to initiating the implementation of any strategy. Look at that data, see if it's relevant, see if we can all cross-match it, and then get education on the inquired training from RNAO, continue collecting data, and continue monitoring the results. Basically, in a nutshell, that's an evaluation. So they may include a subset of members from the Ontario Health Team BPSO to join the evaluation team to co-design a comprehensive evaluation plan to assess the impact of Ontario Health Team's BPSO on clinical provider, organizational, and system outcomes. A lead researcher has been engaged for this work, who is an expert on implementation science, conducting regular quality improvement and monitoring activities related to implementation of each best practice guideline. Every organization has quality improvement, goes through accreditation, has legislation, ministry guidelines that they're responsible for and are being tracked with. And as such, evaluation will be pulled all together for all the BPGs. So we will measure the success of each recommendation implemented through data collection, measuring baseline data, and post evaluation. And there are scorecards that are developed in many areas, but each organization will be developing them as they move forward. Dissemination. Basically, dissemination is about sharing the information, spreading the word, and spreading the work with everybody in healthcare, not just healthcare, but all across, in all the wonderful work that's being done from our Ontario Health Team, but from all the BPSO, pre-designate, post-designate, anyone that's interested in joining. It's sharing information through a collective identity, social media presence, Twitter, Facebook, Instagram. Webinar, as today is our first webinar for the Ontario Health Team. This is an example of a dissemination of information. The conference is being held this week, the Nurse Executive Leadership Academy. There will be a panel discussion on Ontario Health Team's BPSO at that, as Laurie had alluded to earlier on today. So we're constantly sharing the information, and that's dissemination of all the information that we acquire, and sharing the work and spreading the work that is being successfully implemented within organizations. Through this work, RNAO and partners of the BPSO have established a collaborative partnership with dynamic, mutually beneficial, and focused on implementing and evaluating a tailored BPSO designation that will serve as a model for other OHTs in the province going forward.
And then just to end off, we do want to end off on a high note. So we are having fun together. The development so far of our OHT BPSO has been enjoyable for everyone, and it's provided a unique opportunity for networking and connecting with interprofessionals across sectors. And we're excited for what the future holds for our Northwestern Toronto Ontario Health Team BPSO.
Okay, that's okay. Let it be. Let it go.
It's really exciting to be part of the OHT BPSO. be a part of, and just as a frontline care provider, it's just excited to be part of this initiative from the bottom up and be able to see what happens.
To put on hold. Okay, so I want to just, before we move to the next section, actually open for questions a few minutes. Before I do that, I want to thank Sarah Kirkup, Nikki Mann, and Laurie Martin for a fantastic presentation. I must say that we didn't help them even prepare, so I was saying to Sue McNeil, who is my partner in crime, and to Olivia and to PG, that we may as well go home. Thank you very much. You guys don't need us. I think you can take the show over. It's really quite amazing. I just wanted to highlight a few points for those of you that have not been involved with Vpsos. First of all, picture in December 2nd and 3rd. If this is the type of already performance you see in this room, amongst 25 people that are coming from these 13 partners, just picture what will be December 2nd and 3rd when 130 frontline staff come to be educated on evidence-based practice and on staff engagement and on person-centered care, which will be the guideline that we will use, how they will feel having this type of engagement. I also want to acknowledge Janet Squires, who is likely listening, I hope, but couldn't be here in Toronto, that will be working with us on the evaluation of the OHT, and that will serve also as the prototype for future OHT evaluations. I wanted also to thank John Lavis, who is the co-chair of the Enquire team, the Nursing Quality Indicator for Reporting and Evaluation, who will be alongside with Leslie Thompson, the head of Accreditation Canada, who is the other co-chair, thrilled in pushing us forward. And John, if you are online, I must say, you should feel very proud that we already took the point that you made at the last Enquire meeting on the system for health system transformation. So we added that to the tagline of the Vpso OHT, and I want to thank you for always pushing the agenda and also anticipating that I know you and the Enquire Advisory, which is international in nature, for people to know how much you will be thrilled and the advisory will be thrilled on seeing the progress. This is really quite revolutionary, and we are very excited of working with the OHTs. And yes, others are asking us, and yes, we will take others, but on a priority base. We already have 2 that are signing an agreement, but if others are interested, please send a note to, my staff is looking already at me. Please send a note to thegrinspun@rno.ca. We will put it at the end, or PG will add it, and copy always PG because nothing happened if not. And we will consider others as time moves forward. I also want to thank Sue McNeil, Olivia, and PG, who work with me very closely on this. Megan Bamford and her team, she's in charge of guideline development and evaluation. And Heather McConnell, who is in charge of knowledge transfer, and she's actually in an activity today. So to all of you and the partners of the OHT that are here, thank you. All of you stay here, so thank you very much. Amazing presentation. And we will open for questions because there are some questions. And then we will move to Michael Groth to present about the public health. Yes. So what's the question? I can't see that. If you can read it, you can read it. So clients are absolutely well included, and maybe I will take our colleague from Saint Elise that is sitting here. If you can come and share how will Saint Elise participate, or I can advance that so you don't need to make all the way here. So community partners, whether it's in primary care or in home care, where we see clients, not patients, will be absolutely included. They are part of the OHT. They will apply the same guidelines. So the 2 guidelines that are mandatory for any OHT that works with us as Vpso OHT, is transitions in care and person and family-centered care. And the two that this OHT chose for implementation is falls prevention, which happens at home or in the street or at work or in nursing homes or in hospitals, as well as pressure injuries, which of course, unfortunately, we see also that in homes as well. I don't know if you want to add anything from St. Elizabeth perspective, please. Let me give you the floor. Okay. Introduce yourself.
Hi, good afternoon. My name is Kristen Campbell from SE Health. Just with respect to the question related to engaging patients and families, we have been doing co-design sessions where we include patients and families in the conversation to move forward with our clinical models of care. I think that's the best way to engage patients and families in this change to our healthcare system.
Thank you very much. And just to augment that in relationship to the training on December 2nd and 3rd, in fact, one of the aspects that we stressed this morning is that organizations, whether home care or hospital care for that matter, if they want to also bring some patients that or families, in the case of long-term care, that want to be involved and want to become champions, by all means, it will be fantastic. This is for the 130 people will be members of the interprofessional team, including patients and family members, and also including regulated and unregulated staff. Another question, if you can. So person and family centered care is actually one of the key pieces within the OHT application. So it will from the get-go, and that's why we selected that for year one, and then for year two, transitions of care when things start to move forward. So absolutely in sync with both the population of this OHT, but also the requirements of the OHT in general. To remind you, the Northwestern Vpso OHT is a component within the broader OHT. So while at the OHT, they're looking at the issues of governance, the issues of funding, the issues of etc. Here we're looking at the evidence-based practice across the continuum. So the fact that they're implementing the same VPGs across the continuum will provide that continuity of care, in addition to the person-family-centered care, also on clinical issues application, which is very important. Thank you for the question. Well, that will be an interesting partnership, because the regional office will be, if they are already formed and established, will be actually invited if they so wish to come to the December 2nd and 3rd, or at least to bring remarks, because it is critically important that we be totally in sync with the regional office, as well as with the overall OHT, because together is that we will advance the things. In one of my earlier webinars, because we started these webinars in April, at the beginning only open to nurses, then open to another question or we move to David? I just don't want to eat into his
We
time.
can- we
I
can
think
do
we
it.
will move to David and we will answer to other questions. If we can link David so he can, thank you.
Hi, can everybody hear me?
I can hear you.
Excellent. So I want to thank RNAO on behalf of OPHNL for having us here today. For those of you who may not be familiar, OPHNL, so our association vision is to promote and protect the health of Ontarians through excellence in public health leadership. And our members consist of leaders in public health nursing, including chief nursing officers, nursing directors and managers, and professional practice leads from across the province. And we have about 120 members in our association. Now, before we get into the report, I know Doris had touched a bit on some of the changes, but I wanted to also add, so not only are we moving from a 35 health units or health departments to 10 or whatever that final number ends up being, but the funding formulas had also shifted. So we had funding formulas based on a 75% province, 25% municipal funding. Now I've moved to a 70-30 cost shared agreement, and for some 60-40. So quite significant fiscal shifts as well. And we also know that, you know, these calls for reforms are not new, and Doris alluded to an expert panel report that was completed. So that was completed in 2017 under the previous government. So calls for reform are not new, and indeed, you know, the system could use certainly some changes. And so we wanted to ensure that nursing voice was heard and understood and included in the discussions around redesigning and updating a public health system. So in June, you can advance the slide, please. So in June, the chief nursing officers for our 35 public health organizations met. And at that time, there was a call for a technical table to be pulled together so that we can provide recommendations on this ongoing modernization of public health. And so the report is really seen as an opportunity to ensure our voices are heard in that redesigned system. The report's objective is to support the government in modernizing Ontario public health system and to transform us into becoming more integrated and efficient. The report contains 12 overarching recommendations and focuses on some key areas, including improved quality and consistency in the new modernized public health system, integration with primary care to build successes of each system, to enhance population health, optimization of public health workforce by working to maximize all roles in public health and advocating for appropriate practice scope expansion for nurses, and innovation, including the use of technology for virtual care and sharing of electronic records, which I heard a bit about today, and also through a regional system of setting common standards, approaches to public health practice. Next slide, please. So our report was developed in consultation with a number of individuals, but I really do want to thank RNAO for strategic advice as we were starting to build the report, build on the consultation process, as well as we sought some guidance from the provincial chief nursing officer on how to move forward. So we consulted with not only the 34 provincial chief nursing officers, but we also consulted with our members, so the 120 public health nursing leaders, which represent about 4,000 nurses in public health. We also broaden our scope in terms of reaching out to various roles in nursing to see how nursing in general can be broadened and incorporated within a modernized public health system. So we reached out to RNAO's interest group, so Community Health Nurses Interest Group. We reached out to RPNAO and we reached out to MPAO for their advice. We also reviewed the Premier's Council reports, improving healthcare and ending hallway care, as well as the expert panel report and ECHO, as well as other salient publications. So there are some key principles that are really underlying our recommendations. And first and foremost, which I didn't put up on the slide, but It's about the clients, right? So clients as a first priority and understanding of community's needs and its strength. It was really pivotal in the recommendations. We also want to focus on collaboration between public health and primary health as an opportunity to benefit clients and the system overall. And certainly nursing leaders are instrumental in providing support to public health nursing staff to achieve excellence in practice and achieving positive client and community outcomes. So those were some of the essential underpinnings. Next slide, please. So in terms of recommendations around integration, these recommendations are about maintaining our capacity to offer our core health protection and promotion services while considering strategies that help us better match them to our population health needs. We believe there are opportunities inherent in service delivery at a regional and local system, and that some of what we do naturally aligns with one or the other, and we can maximize use of provincial and municipal funding by redesigning programs and services through that lens. It'll be most important to maintain the flexibility to respond at the level where the response is most likely to have maximum impact. We will need to be accountable for demonstrating the returns on investment associated with the different response options. These excuse me for a second. These recommendations recognize the important role that population health information plays for our health system partners, communities, agencies, and municipalities. And finally, this set of recommendations recognizes that nurses work in a variety of healthcare and other settings, and as such can be one of the public health professions that build connections across systems. Next slide, please. The quality dimension of efficacy and effectiveness are fundamental to effective public health services. This means that we have to be diligent in our pursuit of new approaches that will help us tackle complex and challenging public health issues, like belonging and its connection to opioid use. It's incumbent on us all to work with our community and health partners to design effective downstream solutions that will help us save lives and health. At the same time, we need to be building on our and others' knowledge of social and environmental determinants of health to co-design interventions that make the healthy choice at best no choice at all, or next best, the easiest choice. We need to continue our work with our public health, municipal, education, and other partners to physically and socially construct environments where health opportunities don't come by choice, but by design, and to include the public in our vision of a future where this is possible. There are also opportunities associated with the creation of Ontario health teams, for example, in the creation of shared care pathways. As these teams form, it will be important for public health units to position themselves to be, at a minimum, collaborating partners at the table. And this will allow us to keep connected with the progress and practice of the teams to develop a sense of where opportunities lie for deliberately designing care pathways and how they intersect, such as through the management of TB. Next slide. We believe that public health offers valuable contributions to decreasing demand on acute care services through our health promotion and protection work, preventing outbreaks through infection prevention and control recommendations, limiting the spread of vaccine preventable diseases, promoting built environments that offer easy access to healthy food and physical activity, promoting school and community environments where people feel safe and valued, all contribute to decreased morbidity and mortality. As each health unit builds its understanding of local drivers of population health, we have the opportunity to explore nuanced solutions that suit our context in partnership with our municipal, community, and social service partners. What works in large urban environment may not be what's needed in small urban, rural, or northern environments. And we already have access to potential measures of our success, including morbidity, mortality, quality of life, and ER visit statistics. Public health modernization may also provide an impetus for us to consider whether there are areas of uncharted territory where the addition of a public health lens could support system change and improve the health of all Ontarians, example through our involvement in correctional services. As we build new roles for public health nursing, it's time to consider how we create a new public health practice that synthesizes primary care and population health principles and practices and share learnings with our health system partners, so the right person's doing the right job at the right time. Nurses are one of the largest workforces in many healthcare institutions. We believe that provides our profession with the opportunity to build connections across organizations and practices using our shared values, language, and practice. So we've also provided some next steps with the report and following the report, and we believe that it's important to embed nursing leadership in public health governance and policy framework in the recognition of proven connection to safe and effective public health practice. So in essence, we believe that our nursing voice should be situated within the frameworks that the provincial government is building at this moment. And we also need to look at develop a program and service pathways in public health nursing that maximize nursing scope and practice in preparation for system work with the Ontario Health Teams and other system partners, such as RN prescribing. The next slide. We also believe that as the system moves forward in the modernization, that there are various tables that our association should be incorporated within, and or there should be tables that are developed so that as the system progresses along and is developed, that our health system related recommendations as well as our recommendations around public health nursing are incorporated. If you do want to review the report, you can visit our website at ophnl.org. And I just want to thank Hamida Bamani, who's the president of our association, Kathy Walker and Esther Bogdan, who are both chief nursing officers, for their leadership and direction in development of the report. Thank you.
Thank you so much, David. And we will open again for questions about any of the aspects of today's webinar. Either the piece on health system transformation, the OHTs, the presentation by my colleagues on the Northwestern Toronto OHT, or David's presentation. Are there any questions? I believe you have a couple. Maybe you can read the one you have. Okay, fantastic. So if there are no more questions, let me ask you the following. As always, I do at the end of the webinar. From 1 to 10, if you can just shoot a number through your bubble there. 1 meaning not useful at all, 10 meaning very, very useful, so we know how it works. Also consider, as you put the number, of how important was to have partners, because the plan is that in October, when we are presenting, and the date is October, I have sent you this, the date is here. So the next one is October 28 from 2 to 3. The idea is to bring the second Vpso OHT to present on their progress. And I just want to know if this is something useful. It is certainly for us. I feel very proud and privileged to actually hear my colleagues presenting already and seeing how informed and excited and knowledgeable they are. And I just want to make sure this is useful for everybody. We are getting lots of 9 and 10s. That's fantastic. Okay, so that means it's a go for October 28th. And if you have questions that are remaining, please send them. We will be happy to answer. If you don't have questions but have suggestions, similarly to David and his group that asked if they could present, likely at some point we will bring our ECHO model. You may remember the famous or infamous ECHO, Enhancing Community Care in Ontario. You may want to Google it to refresh your minds. Enhancing Community Care in Ontario. The first report was in 2012. The second, because no one listened to us, was in 2014, but then they listened to us. And that's when CCACs were merged into the LINs. We did ask at the time that the care coordinators needed to be in primary care. ECHO 3.0, which will be released in February, will continue to ask that care coordinators is 4,500 of them, just so you know. Most of them are RNs. We will continue to ask that they be in primary care, not because we like our colleagues to my left here and all the primary care teams that are here, but because we know that there is no high functioning system that doesn't have a robust primary care system. So that's really the rationale. We know that we already have about 1,000 in hospital care. It used to be called discharge planners in my days at Sinai. We absolutely do not want them to move out of hospitals. We need those people in hospitals to coordinate discharge, etc. But we need also the uptake in primary care to help people navigate this complex system of ours and transition people from one sector to another in a way that people, Ontarians, don't need to struggle with that they only need to struggle with their, hopefully, they don't need to struggle with nothing because public health will be strong and hopefully, and primary care. So hopefully it's about health, but people during illness time do struggle with a lot of challenges and stressors. They don't need to struggle with navigating the system or remembering to come for whatever test, and they need that support. And so hopefully ECHO Point 3 will support the government in moving. So when someone asks me how will the regional Ontario health link with primary care, I do hope that the Ontario Health Agency and these 5 regional agencies will see fit to move actually care coordinators, not to the Ontario Health Agency, but actually to primary care, to home care, to basically the sectors, so they can do what people need. So you will hear about that before it's released, so we will consult with you. I don't know if in October, but in November for sure. But if the meantime other groups have reports that they want to share, maybe we will invite also John Lavis. John Lavis and the McMaster Forum have a fantastic initiative. It's called RISE, R-I-S-E, RISE, R-I-S-E. I was involved with them when they were developing that initiative. We will be putting together with R-I-S-E, RISE, we will be putting together one-pagers that Arenio is developing on evidence-based practice, how to use evidence, what a Vpso means, and we will be co-branding them with RISE for the consumption of everybody. But if you visit the RISE website, you will see lots of resources already related to governance, related to e-health use, electronic care, etc., which we also have VPGs on that. And you can also look at our guidelines. But there are lots and lots of resources, solid evidence-based resources for everybody to be informed and everybody to be part of this tremendous opportunity. Any other question that we have? So that's a question for government. I will give you my take, and then time will tell if I was very wrong or very right. Usually you can read my columns in the journal. I have been spot on. I mean, I predicted 30 first OHTs is 31, not bad. My hunch is that the links will continue for a short time, that those will be transformed in 5 Ontario Health, regional Ontario Health entities. That's already what is in the slides that I showed at the beginning. We believe that that will be a very good initiative that will bring then the OHTs under those 5 regional Ontario Health entities. And the question about how long it will take until all Ontarians are linked to an OHT, I will give it 6 months before the next election. That's my hunch. And I tell you something, from an RNO perspective, we will applaud if that's the case, because one of the problems of our system has been that we pilot and pilot and pilot, and then a new government comes and they don't like what the previous government did. So this is another pilot. And I think this Ontario Health team, and I said this to Minister Elliott the other day when I saw her at an announcement, stick with Ontario Health Teams. If we all make them work, we will have what is called integrated models of care, which is what patients at the end need. Patients do not just need the hospital, they do not just need primary care, they need all the sectors at different times of their lives. They just need these sectors with good synapses in between. They need these sectors practicing on common platforms that they speak with one another. They need these sectors to practice with the same type of knowledge, regardless in which sector. That's where the Vpsos with the best practice guidelines will be so useful. And they need these sectors to be excited through staff engagement. So I think we also on that are contributing. So my hope, 6 months before the next election, regardless of what the next election brings after, all Ontarians will be hooked to an Ontario Health Team one way or another. The question is on that, and we will be discussing this with ECHO, in ECHO 3.0, is what happens with, for example, the homeless community. How do we connect the homeless community to Ontario Health Teams? How do we connect shelters to the Ontario Health Team? I mean, I went with St. Elizabeth, in fact, with a fantastic nurse a few years ago to a day in the streets of Ontario, of Toronto and to homes of very vulnerable people. And then we landed in a shelter. And I will never forget, we could hear this woman needing likely an x-ray, even not an x-ray, because you could hear the gurgles even without a stethoscope, that bad it was. And yeah, you give her all the tokens in the world. She was not going to go to the street because she was afraid she will be killed, okay? So if in those shelters, for example, we had a nurse practitioner, or if those shelters we have an RN with first line RN prescribing, the same with correctional facilities. So how will we link those vulnerable communities to Ontario Health Teams? It's an important question for us that we are tackling in ECHO 3.0, and stay tuned for that. Any other questions? So the current employees of HSTs, family health teams, should not fear anything, in my view, because I think primary care will be strengthened. That's my view. I don't answer for government or for any FHT in particular. But I don't think that anybody in primary care should worry. If anything, it's your time finally to celebrate, because you should get, in our view, in the view of RNO, additional resources. I believe that the care coordinators, 4,500 of them, a great majority of them are RNs that are care coordinators right now in the LINs. Our hope is that immediately, in fact, we have been asking already for quite a bit, they move to primary care. We know for a fact that community health centers are ready to uptake as many as possible care coordinators. We know that many of the nurse practitioner-led clinics are ready to uptake many care coordinators. I am certain that many family health teams are ready, because I know, for example, Kathy Folks and other family health physicians that are ready to take care coordinators. That has been public in the social media. So I do hope that as we move to the Ontario Health Agencies, to the 5 entities, that instead of transitioning care coordinators yet again to those agencies, we transition them to primary care ASAP, because that's where patients and interprofessional teams need them. Keeping, I must add, keeping their agreements intact. Those people that are moving have a lot of expertise, so it's not about cutting their compensation or benefits. It's moving them to serve Ontarians in a much closer way. You are absolutely right that no new hirings have happened, nor do I think they should happen when there is this level of uncertainty. So I'm quite sure that they froze new hiring in the public health units. However, as David said, we are absolutely determined that both public health executives need to be embedded within the new structure of government. Whatever number of public health units will be, if it's 11, 12, 13, 15, those need to have embedded also public health nurse executives. They play a critical role. And second, the role of nurses. Remember, this will be large entities. So they will require a degree of staff in the front lines. So I don't believe, and we have said this to Premier Ford and to the minister, we do not believe that in a time of transition, you cut funding. In a time of transition, you do the transition. You don't cut funding because then you create double instability. On the issue of 70-30, you are talking about province, municipality. We are asking that that also be put on hold. We do not believe again that in a time of transition is when you start to negotiate what is downloaded to municipalities. So for us, yes, we are supportive of less units because for once we experienced at RNO the quite significant chaos that there was during SARS and in other occasions when you have such a number of large public health units and the capacity of those units, and even that some of them cannot even have a medical officer of health, others don't have a chief nurse officer, etc. But we are asking that the new number, whatever that number is, be not shortchanged on staffing. So we do not want to see positions lost. We need to see positions transferred, and that also the 70-30 split be reconsidered because that will create instability. There is time for looking at savings down the line when we see what those units are doing. For now, we need the people to move with the programs so that no crisis that is, you know, in the front steps of our doors every day, quite frankly, cannot be attended in the way that it did. So I hope that that's helpful. We are also asking for another position that's not in David's report, but RNO is asking for another position. We advocated that in the past, we will continue. So while there is the medical officer of health and there is the chief nurse officer, we're also asking that there be in those large public health units an executive director or a CEO, whatever title it be. That position ought not to be necessarily a doctor, ought not to be necessarily an RN or a nurse. It can be from any profession, but we believe those three positions, the one that is the medical officer of health to deal with what the medical officer of health is best at, the one of the chief nurse officer to look at all the aspects of nursing and interprofessional teams, and the one of the CEO to really look at the operations of such a large unit, which is a completely different skill set than a medical officer of health. I must put a plug here. Many of the chief nurse officers have those competencies, and we believe if that position is created, we will be pushing them to apply for it. Any other question? Not to OHTs, it is my understanding that the public health units will be linked to the Ontario agency regional offices. That's my understanding. If I'm wrong, I will be stand to be corrected. And by the way, we have a fantastic associate director now for the public health, and that's Alison Blair, and she's a tremendous person with tons of knowledge and tons of how to go about things, also very mature on system knowledge and relationships. And also, you may know that the Premier is bringing an advisor for that entire file. Yes, we will send the links to the previous archives, and we will send my columns that are on this, the previous columns. And I want to send you one more piece that I was speaking today with the Northwestern Ontario Health Team, and is the difference between safety 1 and safety 2. Canada, by and large, and Ontario also, and perhaps many parts of the world, have been for many, many years, for decades, speaking about patient safety. And that is in general, the approach that has been taken is what we will call safety 1. And safety 1 is do not do any harm. So for example, incident reports, right? And every time that something happens, a debriefing of that, all of which is very good. The way RNAO looks at it is more not only safety 1, but safety 2. And that's not a name that we put. There are gurus on this. And safety 2 talks not only about going to work, trying not to do harm, but actually going to work, trying to do the best you can every single day. And that's where the best practice guidelines play such an important role. So safety 2 is kind of the upper limit, and safety 1 is the not below here, and it's between the two that I think the Quadruple Aim needs to push the agenda to really start to move the needle of a system that I will call it from novice to expert. That's a model that we use in nursing. From novice to expert, we use for a new grad all the way to an expert nurse. And I would say the system also is kind of moving from novice to expert on this issue of moving from patient safety grounds to patient safety plus optimal care. So we will send that article too. Those are very important. And that was discussed a lot in the Salzburg global seminar that I attended recently, which you can Google for that, and there will be a report, and we will be sharing that report as well. Very, very interesting and important discussions with people that focus on measurement of patient safety from across the world. We had the pleasure of having also Marian Darpino and Gina from CPSI that attended as well. We were, I think, the 3 Canadians, and then the rest people from all different countries, both developing countries and developed countries. And let me tell you, when I filled yesterday the questionnaire on what were the biggest learnings, you ought not to be surprised knowing me, but some may be surprised. I learned probably more from the developing countries than anything else, because the level of engagement they do with communities, the challenges they have, and how they really push the agenda, having very little resources, is nothing short from inspiring, and a lot to learn from them. Thank you very much. If you have other questions, you can send. If not, you can keep them for October 28th. We look forward to seeing you, and we will be advertising already probably that event by the end of this week, so you can start to register, okay? And thank you to the 300 and more participants that came through the webinar. Thank you to David, to you that are far away, and to my colleagues of the OHT here. Thank you to all of them. And next, if you want to hear the commentary of RNAO about, I understand that they released something on a platform about the National Pharmacare. Stay tuned, CBC to come. Take care.